Thank you, everyone, and Dr. Cowley.
Thank you very much. So as Jax mentioned, I am a perinatal psychiatrist, so my focus is on behavioral health in pregnancy and the year postpartum. And, you know, I think I need to advance the slide. Okay. I think I'm going backward. Yes, okay, great. So what I'd like to talk about is supporting people with perinatal mental health disorders and substance use. And, you know, those of us who are perinatal psychiatrists, I think, tend to look at this like we want to support people, you know, parents during this process, and also make sure that children get off to the best possible start in life. Okay, so I'm going to try to go forwards here. Okay. So I don't really have any disclosures or conflicts of interest, except that I am the medical director of the University of Washington Perinatal Psychiatry Consultation Line. So this is a free service. It's state funded. It's available to any healthcare provider in Washington state who is caring for somebody who is pregnant, postpartum, planning pregnancy, and has issues with mental health or substance use. And we are open. It's a telephone consultation line, so you can call us weekdays 9 to 5, and the number is up here. It's up at the top of the slide. We have a team of perinatal psychiatrists who staff this line and answer your questions. And the person who answers the line is Alicia Curley, who is over here at this table on the side. So you may have met her already. So we'll talk a little bit more later about how we hope to help through this consultation line. So basically what I'd like to talk to you about is screening for perinatal mental health and substance use problems, what to do if someone screens positive, how we can provide support to people through education, referrals, supporting treatment, promoting sleep, which is incredibly important, and then also types of treatments, non-medication, medication treatments, just the approach to medication treatments, and our consultation line. So that's basically an overview of what I'd like to talk about. So, I am going to move a little bit because actually I can't see the slides very well, and I think it would help me to be able to see them. Okay, great. So we know that mental health and substance use problems are actually pretty common in the perinatal period. These figures actually increased during COVID. We're not quite sure exactly where they are at the moment, but they're common. And postpartum psychosis, which is on this list, is not common, but is very serious and is a medical emergency. You can see that even though a lot of people quit using alcohol or drugs during pregnancy, there's still, you know, a significant portion of people who continue to use. And as we've learned earlier today, mental health and substance use combined are, according to the CDC, the leading cause of maternal mortality in the country. And that's true in our state as well. It's primarily due to suicide and overdose. So just a little bit more about perinatal substance use. As you can see here, this study actually did not look at opioid use, but if you look at some other substances like alcohol, cannabis, cocaine, tobacco, or nicotine products, a lot of people do quit using during pregnancy. but the rates of relapse in the first 3 months postpartum are quite significant. So that's a particularly high risk time. And we would think, these conditions are common. So of course, we would be looking for them and treating them. However, if we look at this example, this was a study of postpartum depression, and it showed that in this particular clinic system, only 50% of people who had postpartum depression were screened. 31% were identified as having postpartum depression. 16% of them had any kind of treatment, and only 3% were treated to what we call remission, which is where somebody no longer meets criteria for a clinical depression. So we have a lot that we can do to improve these kinds of statistics and get people the help and support that they need. And as the focus of this conference, has been health inequities in perinatal mental health, which, as we know, are significant in general, and are also true for perinatal mental health. So just a couple of things from here. Perinatal individuals who are Black, Indigenous, or people of color are less likely to be screened and treated for mental health and substance use disorders. And people who are Black, who are birthing parents, are less likely to start perinatal depression treatment, to receive follow-up treatment, and to refill antidepressant prescriptions if they're prescribed an antidepressant. There might be lots of reasons for this, but it is a cause of considerable concern. So let's talk about a case example. So this is Jasmine, who's at 16 weeks. This is her first pregnancy. She tells you she's been feeling down and anxious for the past 2 months. She's having trouble sleeping, her appetite's poor, she's struggling to feel bonded to this pregnancy, and she's withdrawn from her friends. She's having trouble dragging herself out of bed in the morning to go to work. Now, this is somebody who is coming to you with symptoms of possible depression. A lot of people actually will not tell you if they're having these kinds of experiences. They might, for one thing, think that, well, this is not something that really belongs in a healthcare setting. It's not really relevant to like a clinical setting. And you're unlikely to be able to help her. People may be concerned that this represents the fact that they are not going to be a good parent, and there's something wrong with them, that they don't feel bonded to their pregnancy. Or especially with postpartum problems, people can fear that if they talk about it, you'll call Child Protective Services and their baby will be taken away from them. So there are lots of reasons why people don't actually report these symptoms. But she is reporting these symptoms, and so, this doesn't necessarily mean that she has a psychiatric diagnosis, but it is a reason why we might want to screen and find out more. So I don't know how many of you are in active sort of clinical setting. How many of you are actively engaged in sort of clinical settings, seeing clients or patients? A lot, great. So we know that there's considerable variation in how screening is done or whether it's done, depending on the organization you work for, the clinical setting you're in. So I'm just curious to know what your screening practice is with regards to PMEDs, our perinatal mood and anxiety disorders. So, no universal screening and follow-up is needed would be kind of like in Jasmine's case, that if somebody reports symptoms to you, then you might screen them to find out more. Screening for people at high risk might be, say, if somebody has a past history of depression or a psychiatric problem or a substance use problem. Universal screening at least once during pregnancy or postpartum, or at multiple points during the perinatal period. So there's option A through D. How many of you are in a setting where option A is the situation. Like you would pursue things more if somebody brought up symptoms. Say, how about B? People who are at high risk. How about C, that you screen everybody at least once in pregnancy and postpartum? So more people. Or how about multiple time points? So that's actually most people. So this is terrific. So I'm just going to mention briefly some screening tools which you may be well aware of. How many of you have used the PHQ-9? Yeah, quite a few people. So you know that this is a screening test for depression. It's based on the symptoms of major depression from DSM-5. And there are, ratings up here of severity. So we usually consider this a positive screen if the score is 10 or above. Or if the last item to do with feeling that you'd be better off dead or thinking of harming yourself is positive at all. The first two items on here, little interest or pleasure in doing things and feeling down, depressed, or hopeless, one of those is necessary to diagnose major depression. So those two items can actually be used as a screening tool rather than giving this entire questionnaire. Okay, and the other thing that people commonly use is the Edinburgh Postnatal Depression Scale, which was developed for postpartum depression. How many people use this? Okay, great. I really like the EPDS because it has items on it that are particularly helpful in the postpartum period, like I have been so unhappy that I've had trouble sleeping. Because we know that everyone has trouble sleeping postpartum. Having a newborn baby gives you trouble sleeping. So this really emphasizes that the difficulty in sleeping is due to being unhappy. This also has some kind of rough cutoffs for severity, and we think of a positive screen as being like 13 or above. It has 3 items on it which have the pinkish stars by them, which are for anxiety. One is actually to do with self-blame, which I tend to think of as being characteristic of depression as well. But one specifically about anxiety and one is about panic. And actually, despite the fact that this was specifically developed for postpartum depression, both the PHQ-9 and the EPDS are equivalent. I mean, you can use either. They're equally effective for screening. Okay, this is just a screening tool for anxiety, the GAD or GAD-7. How many of you have used this? Great, okay. And this was developed for generalized anxiety. It actually tends to yield high scores if somebody has post-traumatic stress disorder, obsessive compulsive disorder, panic attacks. So it's a generally good screening for different kinds of issues where people have significant anxiety. And then we use, I think a lot of people do in their interview, we ask people about substance use. As a screening tool, the NIDA quick screen is something that we tend to use. Has anybody used this? Not one person, okay. Yeah, and it needs to be adapted a little bit for pregnancy because it asks in the past year, have you used and then a variety of substances? But of course we care a lot about whether people used before pregnancy or in the past versus during pregnancy. And any use of alcohol in pregnancy, of course, would prompt a conversation. And the other thing is that in our state, cannabis is legal. So it's intended in this screen to be under illegal drugs, but of course it's legal in Washington state. Okay, so that's just some screening forms. And then the big question is, what happens if somebody has a positive screen? So, if somebody endorses those items about suicidal thoughts, of course we want to explore that more if our clinical setting, our practice allows that. And we'll talk a little bit more about that. we can reassure people and educate them that actually, depression, anxiety, whatever, are pretty common during this period of time. They do not mean that you're a poor parent or you're going to be a poor parent, and you can get help with them. We do also want to make sure that we figure out what is going on, because these screening tools do not by themselves make a diagnosis, of course. People could have high scores on depression and anxiety because of any number of things going on in their life, because of other kinds of conditions. So we do want to explore that a little bit more, and that might involve doing it ourselves or referring them to somebody else. And then we want to make sure people get whatever treatment or help or support they need. If we refer people, from a community setting, from a primary care setting, to mental health evaluation or treatment, the follow-up on referrals is pretty low. Depending on the study, it's 11 to 37%. Sometimes it's helpful to talk to people in terms of stress as opposed to they're having a psychiatric problem or depression or whatever. But usually, sometimes behavioral health services are in your same location, which definitely facilitates referrals. And increases in referral rates have been shown if we educate people a little bit about what we're talking about, engage their family, partner supportive people in encouraging them to follow up with referrals. And if we do what we call a warm handoff, like actually communicating with the person who is going to be seeing this person, having your client or patient know that you're doing that. So this is kind of a personal referral or handoff. This picture on this slide is of an NIMH brochure. How many of you have seen this before? It's an NIMH brochure about perinatal depression. It's a very nice educational brochure, and it's available in English or Spanish. Okay. So there are a couple of screening tools that I'm just going to mention here for looking into suicidal thoughts more. And these can give you some suggestions for a conversation that you can have with somebody about this. Oftentimes people will have thoughts about wishing they were dead or wanting to harm themselves because they feel so miserable and overwhelmed. But they might tell you, I would never do anything about this because I don't want to harm my child, I don't want to harm the pregnancy. But these kinds of questions can help you sort out whether this is something that is urgent. We want to empathize with people that this does reflect feeling miserable, and that we want to support and help them. But you can explore this more by asking things about, have you actually had thoughts about killing yourself? Have you been thinking about how you might do this, like making a plan? Have you had thoughts and some intent of acting on them? Have you started to work out or worked out the details of how you would do this? Do you intend to do this? Or have you done anything, started to do anything, or prepared to do anything to hurt yourself? So it gives you a series of questions to explore things more. And it gives you some guidance at the bottom about what to do if people answer certain questions in a certain way. The other scale is the Ask Suicide questions from the NIMH, which similarly goes through a series of questions. And if somebody says yes to one of the first 4 questions, you ask the 5th one, which is, are you having thoughts of killing yourself right now? In which case, obviously, we all know this is an emergency. So we can transition to types of treatment. So there are some non-medication approaches to treatment. If people are having depression, anxiety, other mental health or substance use issues during pregnancy or postpartum. These include things like peer support, engaging family, and whatever social support somebody might have. There's a variety of resources also that were represented in all the tables that were around here earlier. There are some evidence-based forms of psychotherapy or counseling which have been shown to be effective in the perinatal period: cognitive behavioral and interpersonal therapy for perinatal depression, for example. But oftentimes people will respond to counseling that has to do with dealing with stressful life situations, things that they're facing at the moment, or therapy that's been helpful for them in the past. A really important thing to do in this time period is addressing sleep. We obviously know that this is true in the postpartum period, but actually sleep starts in many people start to have disturbed sleep early in pregnancy, like even in the first trimester, and certainly by the third trimester when you're so uncomfortable and it's just difficult to sleep. And poor sleep during pregnancy has been associated, it's shown to increase the rate of preterm birth. So addressing sleep is really important. And there are non-medication treatments like cognitive behavioral therapy for insomnia, which there are apps and websites about and that kind of thing. Addressing sleep in the postpartum period, I'll talk about more on the next slide. Morning light therapy has been shown to be helpful in the perinatal period, even if it's not winter. Exercise, and for substance use disorders, motivational interviewing, like assessing how motivated someone is to quit or cut down, self-help groups, and again, cognitive behavioral therapy. And there may be other non-medication approaches that you know about or use. So sleep is a really important modifiable risk for especially postpartum mood or anxiety. And you know, the postpartum period, like the postpartum month especially, is the highest risk time in your entire life of having a psychiatric hospitalization, a mood or anxiety problem. So the goal that we have, you know, from a mental health perspective is 4 to 5 weeks of continuous nighttime sleep, which you could look at that and say, well, that's totally ridiculous. You know, postpartum, nobody is going to be able to sleep for 4 to 5 hours straight. So we do what we can. You can engage the person's partner, a support person, in doing a nighttime feeding. Oftentimes people don't want to do that in the first month because they want to make sure that breast or chest feeding is well established and not, you know, that the baby latches and is not using a bottle. So, you know, you do what you can, like maybe the support person, the partner can do things like get the baby when they're crying, change them, bring them to the parent who's feeding, and stay there the whole time to make sure this is done safely while somebody's half asleep, and then changing again if necessary. There's a perennial issue of do you change babies before or after feeding, and then getting the baby back to sleep. So you can do things to support people's sleep, which is really important. Occasionally, we like to support nursing. Occasionally, you know, people will have such a severe history of psychiatric problems, like especially bipolar disorder, that their mental health is going to be really adversely affected, or is adversely affected. And then, you know, we try to support people in whatever decision that they make. The other thing about, you know, sometimes people take sedating medications for mental health reasons, and if this is the case, they shouldn't do this unless there's another adult in the home who can respond to the baby. And also we recommend against co-sleeping. Okay. All right, so here's another case example. So Maria and her partner would like to have a child. So the consulting knew it. I love it when this happens because 50% of pregnancies are unplanned. So it's nice when you have the luxury of thinking about this before pregnancy. So Maria has a history of bipolar disorder and opioid use disorder. She's taking lithium and buprenorphine in the form of Suboxone. And she's wondering whether she can take these medicines during pregnancy. So, we may be thinking about medication treatment, and most people, we and most of the people we see, would prefer to avoid taking medications in pregnancy or lactation if at all possible. Sometimes people have, severe symptoms. Sometimes people like Maria are on medications when they get pregnant or when they're contemplating pregnancy. And our general goal is to use the lowest number and doses of medications possible while effectively treating the underlying disorder, because actually we know that depression, anxiety, it may be more obvious if this is true of substance use, have significant adverse consequences for the fetus and children. So usually what we do is have a risk discussion. So what we might be doing is discussing, if we're prescribing medication, what we do, and it's an option for treatment, we talk about the risks of the untreated mental health or substance use condition. We talk about the risks of the medications, and we talk about alternative treatments, like non-medication treatments or alternative medications that might be safer during this period of time. So in Maria's case, we'd be talking about the risk. One of the things that she's on is something for opioid use disorder. So we talk about the risks of opioid use disorder, the risk of buprenorphine, and alternatives. So just, to play out this example, what are the risks of opioid use disorder in pregnancy? Well, one of the risks is overdose, which we have seen, is a cause of maternal mortality. The birthing parent is maybe less likely to receive appropriate prenatal care. There's a risk of infections like hepatitis C, HIV, and so forth. There's a risk of the opioid exacerbating psychiatric symptoms. The rate of unplanned pregnancies in somebody who has a substance use problem is about 70%. There's abuse or other trauma associated with use of substances and legal consequences. And to the baby, there are a variety of adverse effects like intrauterine, death of the baby, stillbirth, preterm labor, low birth weight, withdrawal symptoms in the newborn, decreased breathing, suppression of breathing, longer hospitalization after birth, and a higher chance of the baby coming back to the hospital in the first month of life. And if she stays on the buprenorphine, then we would expect, she might be more likely to be engaged in prenatal care, have decreased rates of infection, a more stable environment, decreased overdose risk, we would hope, and decreased rate of withdrawal in the baby. So then we would look at the safety of the medication. And actually the data about buprenorphine and methadone are actually pretty reassuring. And in fact, most medications that we prescribe, if people have mental health problems are, relatively, they're not things where we say, oh my goodness, you should immediately get off this medication, except for Depakote. How many of you have ever seen anybody on Depakote? Depakote is a major teratogen. If you take it in doses that we usually use for bipolar disorder, it has about a 1 in 4 rate of birth defects in the child. So we really don't want anybody of childbearing potential to be taking Debica. Buprenorphine specifically does not seem to increase the risk of birth defects, miscarriage. Infants tend to be smaller on average. There is still a risk of withdrawal symptoms, with 20 to 60% requiring treatment. It seems as though the severity of withdrawal is a little bit less than with methadone. And interestingly, there doesn't seem to be an association between the dose that the parent is taking and the severity of withdrawal. So it may be more to do with the sensitivity of the baby, or we don't know what, but that's interesting, and it's true with methadone as well. And withdrawal is more likely if you're using multiple substances. And it is compatible with lactation. So this is all very reassuring information. So as far as medications, what can we do to support somebody like Maria who's already taking medications? Well, first of all, we, and I'm saying as a psychiatrist, we psychiatrists and I think other people who prescribe medications don't always think of talking to somebody about what the risks of their medications would be if they happen to get pregnant. So, we should do this. And it's kind of understandable if you're treating someone in the hospital and they're psychotic and they maybe wouldn't understand what you're saying. But at some point shortly after, when someone's stable enough to have this conversation, we should be telling people what the risks are. And somebody might say, oh, I have no intention of getting pregnant, but as I mentioned, 50% of pregnancies are unplanned. And if somebody has an unplanned pregnancy and no one has told them about the risks of their medication or how this would play out if they're pregnant, they're likely to suddenly discontinue their medications, which is not necessarily a good thing. If you're not a prescriber, then supporting somebody seeing their clinician or contacting them as soon as possible. Maybe they have an appointment in a month, but they need to contact them right away to consult them about their medications, rather than abruptly stopping their medication. And, if somebody's having side effects, like they're put on a medication in pregnancy, they decide to take one, then, of course, encouraging communication with their prescriber. So these are all things we can do to support people. So I wanted to tell you a little bit about our consultation line. I mentioned earlier that any healthcare provider in Washington State can call. So you call this number, 9 a.m. to 5 p.m. weekdays is when we staff it. And usually this involves something like a 2 to 3 minute intake with Alicia. And then about 80 to 90% of the time, you would be directly connected to a psychiatrist if you want a psychiatric consultation. You might actually primarily have a question about resources or referrals, in which case you would talk to Alicia. But if you're calling for psychiatric consultation, most of the time we do a direct connection. If not, it's usually within a few hours. And then we send a follow-up note within 24 hours, just to document and summarize the conversation. So you might want to use this service yourself or recommend it to somebody who is, caring for the patient who you think would benefit from it. We also have a perinatal mental health care guide. I've put the link on the bottom here. And this is brief modules about the treatment of different kinds of disorders and issues during the perinatal period. Our newest one is about infertility, but there are also ones that are focused on like depression, bipolar disorder, assessing safety in terms of like intimate partner violence and suicide or thoughts of hurting the baby, that kind of thing. Okay, and this may be all I have. Yeah, so basically, the take-home points are that, to support people with behavioral health issues during the perinatal period, We would really like to see universal screening at multiple points during pregnancy and postpartum. Actually, just parenthetically, the suicide risk in the perinatal period is highest 9 to 12 months postpartum. So we really do like people to be screened, up to a year postpartum if at all possible. Referral treatment, ensuring treatment that is effective. We went over some screening tools, responses to a positive screen, and treatments can include psychotherapy, addressing sleep, and other non-medication approaches, which we recommend, even if we're prescribing medication. Medications may be indicated but require this kind of risk discussion and active engagement of the client or patient in decision making. And support also involves, encouraging people to follow up on referrals and treatment, and encouraging communication or communicating yourself with other members of the team. Because oftentimes people in this period are just interacting with all kinds of different people, and they may get different messages from different people. Okay. So I think that's actually all I have. Thank you for your attention, and very happy to answer any questions or hear any comments or hear from you what you have found effective or helpful in supporting people.